So tell me, what is the overall philosophy of the QA process at Albuquerque Fire Rescue?
So the philosophy of our QA process, I think, really drives everything that we do and drives the success of the program. The underlying assumption is that our providers are out there sometimes in very difficult circumstances, dealing with patients sometimes on the worst day of their life. And we recognize and understand that. And if there's ever any gaps identified in patient care or areas for opportunity for improvement, we do our best to address that on the lowest level. They're on scene immediately if we can, and if it does rise to the level of needing some supervisor input or even medical director input, the assumption is still there that people are doing their best, and there may just be a knowledge gap. And so the understanding that most things are easily remediated. We find that our providers have very accepting attitudes towards this. Everybody wants to learn and get better and do the best for our patients. And over the last couple of years, I think because of this driving philosophy of encouragement and support and remediation, we've seen really an increase in self-reporting and transparency and people very willing to ask questions or have their calls reviewed for input on how they can do things better.
So as opposed to individual provider issues, what kind of systems issues have arisen through the QA process?
This is really where I think our process shines. We have basically constant situational awareness of what's going on in the field, and this is due to our EMS supervisors who giving us a report every shift. I'm constantly reviewing charts, and we can identify trends and issues very early before they become a problem. There's several examples of how this has worked really well for us. One simple clinical issue was that I had noticed very early on that we weren't using CPAP very much in our patients who were in severe respiratory distress. And as we started to work with our training staff and with some of our newer paramedics on the equipment that we were carrying on the trucks, we realized that it was actually an equipment issue, that our CPAP that we were using was very cumbersome to try to integrate a nebulized aerosolized treatment into the CPAP device, and it would fall apart once you got it together. It was very complicated, and so because of that, nobody wanted to use it, and patient care was not as good as it could have been as a result. And so through this process, we were able to identify some equipment issues, make it better. It was an easy switch of equipment, and now our respiratory distress calls are some of, I think, our strongest clinical care that we do. So the patients benefited in the end. Some other issues that have arisen through the QA process that I think are really a testament to the collaboration and the communication in this division, I can think of several. One has to do with the fentanyl crisis. Early in COVID, everybody was focused on respiratory illness and COVID, but we started to notice pretty early on a spike in our fentanyl overdoses. Fentanyl had just arrived in the streets about the time that COVID did, and saw a spike in our young adults who were dying from overdoses, prompted us to reach out to the toxicology, the poison center, collaborate with them, and also the Office of the Medical Investigator to catch this epidemic very early and start to mobilize resources to help with this problem when it wasn't really the national focus at the time, but it needed to be our local focus for the folks that it was impacting. Really prompted us to collaborate with some local partners to address a very big issue in our city. Currently, because of those relationships we built in 2020, 2021, we've also noticed that unfortunately we've had a lot of pediatric exposures to fentanyl that will come in through the 911 system for a toddler or an infant who may have been exposed to fentanyl or some illicit substances, but these come in as seizures or choking calls and not necessarily overdose calls. And so because of this recognition of these sick toddlers, we've been able to change our educational focus and emphasize giving Narcan to some of these toddlers who present with altered mental status or maybe some questionable complaints that don't quite make sense. And this has honestly been a lot of collaboration with our child abuse response team at the state, at the local hospital, and also with our toxicologists again. So those collaborative relationships that have stemmed from EMS notification and early warning of these issues in our community has been really beneficial for our patient outcomes. Another one I can think of specifically for our providers is that we do have a large population with agitated behavior that requires chemical restraint for their safety and also the safety of the providers who are responding to the scene. And we started to track how many of our providers were being assaulted by these patients, whether hit or kicked or spat on or punched. And as we've started to track that information, we've been able to collaborate with local hospitals because the EDs, the emergency departments, are experiencing these same types of dangerous behaviors from patients as well as law enforcement. And now we have a quarterly meeting where all of the EMS agencies in the local area get together, talk about these issues along with the hospital. And we made some big steps forward last quarter where the district attorney actually attended this meeting with the intent to enhance provider safety and figure out ways to effectively move these cases forward to keep our providers safe on the streets. And this all arose through our QA process, noticing that the streets were getting more dangerous for our EMS providers.
What are some benefits to the QA monthly meeting?
Actually, the QA monthly meeting is my favorite meeting of all the meetings that I go to. Not only is it a chance to see everyone in the division who's working so hard and doing amazing things, but it's really, I think, an embodiment of excellent communication. It is a chance for the providers who are actually in the field to come and have a face-to-face with leadership and talk about the way things are on the streets, what they're encountering, what issues they're having. We have pharmacy represented there so we can hear about maybe drug shortages that are impending or equipment issues that we're having. And it's a chance for leadership to truly listen to what's going on in the field. But it's also a chance to hold leadership accountable and address and close the loop on issues that may have come up in the last meeting. And so it's a really excellent demonstration of two-way communication between frontline providers and EMS leadership to try to handle issues that arise in the most appropriate, quickest manner possible.
Okay, and as the medical director, what trends do you currently actively monitor
Okay.
for quality process purposes? And see, my question to you won't be on camera, so it's fine.
Okay. Okay.
I'll ask it again.
Okay.
As the medical director, what trends do you currently actively monitor for quality purposes?
As the medical director, I do enjoy going to the QA monthly meeting because I can directly hear from providers about any issues that they're encountering. A lot of times people will bring up questions about the guidelines and things, wording that may need to be adjusted or things to be clarified in the guidelines. I also actively review provider charts every month, and so I do my best to review every procedure that we do and every medication that we give. Can't say I do 100% compliance with that because we do run about 7,000 calls a month, but I do my best to identify the high acuity calls, sometimes even the low acuity calls and the refusals to see what I'm noticing in terms of patient care, in terms of trends, in terms of call types. Right now, Albuquerque is in the midst of a lot of gun violence that goes along with our substance abuse problems, and I actively monitor our patients who have sustained penetrating injuries to see how we can provide better care to them with the aim of hopefully one day being able to administer blood in the field to our sickest trauma patients and get them the care that they need as fast as possible.
So what are the metrics that you review as a team each month?
So as a team each month, our records management division is able to provide reports on how often we're doing high acuity procedures and just some of the basics in terms of patient care to make sure that we're maintaining high standards. So we follow things like intubation rates and success rates to see if we need to do any extra airway training. We also make sure that aspirin has been administered for chest pain, or EKGs have been obtained in patients who are complaining of syncope or shortness of breath, where it may not necessarily be obvious that they need that, but we encourage those providers to do those procedures on those patients. We also get monthly reports on things like how many times providers have been assaulted, how many times we're leaving Narcan behind with patients who have received a narcotic reversal on scene but then don't want to go to the hospital. We leave Narcan behind with them to make sure that if they do happen to overdose again, which we know is a high likelihood, hopefully someone around them will be able to treat them and keep them safe in that circumstance. We also are able to track certain medication uses. Right now, we just incorporated droperidol into our system, so we're tracking that very carefully. And I get a report every month with how many times we use that and when we use that drug to make sure that it's appropriate and safe, and then be able to reach out to providers if they have any issues or questions about how or when to use that drug.
That was great.
Okay. All right, and I guess the last one's just credentialing, huh?
Mm-hmm.
Okay.
And I can't see that paper.
You can't see it? Okay.
Ready?
Mm-hmm.
All right, so tell me, how do you incorporate new providers into the system?
So we have a credentialing process, and I'm actually really grateful for this because it's a chance for either newly graduated paramedics or paramedics who have come into our system, maybe from another agency, to sit down in front of EMS leadership and basically showcase their skills. We give them a book with our guidelines and some easy rhythms to review for cardiac knowledge, our formulary, and once they feel comfortable, they can sit down with EMS leadership and myself to go through some scenarios, talk through the guidelines, make sure they're good to go and safe on the streets. It's nice for them because they do get some face time with EMS leadership. It's nice for us because we get to know our providers. In a big organization, it's nice to have a face to put with a name and have a little bit of understanding of their approach to patient care. I think it's been really beneficial, and this is actually where we've noticed some trends either from from providers who are recently graduated from school, maybe things we need to emphasize a little bit more in training or in our guidelines, and we get a lot of good feedback that way, and I think continue to improve the system. Okay.
It's just off the head.
Yeah.
So are there any challenges that you're still working on or things that you would like to see improve in the system?
Honestly, I think we do an excellent job. I'm so proud of everybody. I spend most of my time when I review charts, I send more kudos than anything. I wish there was a way we could just highlight how good people do. I love the way that we work together. I love the way that we take good care of patients, always put the patient's needs first. One of the ways we've tried to highlight this is through our case studies. As we find cases that are really exceptional or rare or really have good learning points, we're bringing those providers up to talk about those cases on camera and share that knowledge and those learning points with everyone else. One, it highlights their excellent patient care, but two, it also gives everybody a chance to truly learn from another provider who is in that circumstance. So if they see it again, we're building each other up and preparing other providers for future patient encounters.
Are those case studies that you mentioned only for internal educational use, or are they available to the public as well?
Those case studies are available on our YouTube channel, so we're sharing them. I think they're going all over the world. Whoever has public access to the AFR channel on YouTube can see our cases and learn from them. They are Albuquerque specific and they are ALS paramedic specific, so we do get some questions sometimes about things maybe a physician would do or hospital level care, but they're very much geared towards pre-hospital care in the ALS busy metro environment. That was a good question, John. I don't know other things I'd like to see.
Yeah,
mentioned.
but you took the high road and it's excellent.
Okay. Blood. What do I want to see next? Suboxone. I think that's really it.
You want to talk
My
about
5-year
blood?
plan. No, we don't need to. Do we need to talk about EKGs? the weekly EKGs.
Well,
are
and I
not.
thought you were gonna throw that in.
I
with
mi-
the,
I missed
with
the chance.
With the case studies. And then it was a shameless plug for the YouTube.
Okay, they can cut it though, right? You can just ask me what else have
Yeah,
we,
I could do that.
what other educational materials
it.
have been driven by the QA process.
Okay, so that's the question. So tell me what other education has been developed through the QA process?
So over the course of my first couple of years here, it came to the surface that cardiac rhythms are difficult for everybody. And it honestly just takes a lot of practice and seeing a lot of them and going through EKGs methodically to get good at reading them. And so we were able, with the support of our educational staff and our recording studio, to put together weekly EKGs that I had actually saved from the field. So these are real cases that came straight from our life packs with patient histories and presentations, and we're able to review them together, read them the same way every time, and basically walk providers through how to read EKGs effectively and then talk about the treatments. And we would do that every week. We did that for a year, so we think we did 52 EKGs, all different types of rhythms, all different types of presentations to help people with their comfort level in terms of cardiac rhythm identification and treatment.
And last question, if you had to talk about one exciting new development that's been brought into your system, what would that be? What would that be?
What are you thinking? Okay. If I could have my wish, I would love to be able to provide whole blood in the field to our sickest patients who are in hemorrhagic shock. Whether it is trauma from a gunshot wound or trauma from a motorcycle crash or even a postpartum hemorrhage, having blood available in the field would make a huge difference, I think, in our patient outcomes, and is the next big challenge for us as EMS leadership to try to figure out how to make happen in our city.